Good day, everyone. We are a group from BS Medical Laboratory Science 3-1, which will be discussing a topic that is frequently mentioned in the field of medical technology and internal medicine. It still holds significance and contribution in the causes of disabilities worldwide, especially in Europe and United States. This topic also remains to be poorly understood and recognized in the community among categories of diseases. This topic that I am referring to, of course, are the autoimmune disorders. Before we go into the details of this topic, let me introduce first my group mates. We have Aliyah Audrey Abiera, yours truly Michael Vincent Algozo, Janelle Averillon, Rizel Lirio, Bignon Lianado, Andrea Luis Manalo, and Thea Mendoza. These are the learning objectives. First, we are to describe and to be reminded of the nature of autoimmune disorders, as we will briefly explain the overview later on. Second is to compare organ-specific and organ-non-specific diseases, and mainly to describe and characterize autoimmune disorders from different systems, as we will be introducing them later on. To start with, let me just emphasize the definition of autoimmunity, which is the breakdown of the immune system's ability to distinguish between self and non-self. This just means that the body has undergone failure in recognizing its own cells and tissues as itself or self. This usually involved a varied group of around 80 severe and chronic disorders that shares a similarity, which is the immune system being dysfunctional or misdirected, leading it to attack the organs which were supposed to be protected. Hence, the Semper definition, it is a circumstance where the body is attacking oneself. As no single theory or mechanism has been identified as the official cause, autoimmunity is always associated with an abnormal interaction of lymphocytes with autoantigens. This being said, the potential for this is constantly present in every immunocompetent individual because these lymphocytes that are potentially reactive with self-antigens are observingly existing in the body. Now, autoimmune disorders are being observed when there is a persistent activation of immunologic effector mechanisms that alter the function and integrity of individual cells and organs. In light, autoimmune disorder as a term is being demonstrated when autoantibodies or immunoglobulins expresses a specificity for self-antigens or autoantigens. And with this, it contributes to the development of disease or the observance of the pathogenesis. For example, pernicious anemia, one of the autoimmune disorders, was observed with the occurrence of autoantibodies targeting its self-antigens, which are parietal cells. It is also worth taking note that the sites of organ or tissue damage depend on the location of the immune reaction. The variety of signs and symptoms seen in patients with autoimmune disorders is reflective to the various forms of the immune response. And with this autoimmune disorders, we have these examples. Autoimmune disorders, as mentioned, has various set as its scope. These disorders are currently being classified from a spectrum based on tissue target and reactivity. Generally, there are two ends of this range of diseases. At one extreme are organ-specific disorders, which are characterized by lesions and autoantibodies, which are targeting a single organ. At the other end of the spectrum are disorders that manifest as organ non-specific diseases. This is being observed by lesions and autoantibodies which are not really confined at a single organ, unlike the organ-specific disorders. It is also worth mentioning another subclass from the spectrum, which is called the mid-spectrum disorder, being characterized with localized lesions in a single organ and by organ non-specific autoantibodies. In short, a mix of both extremes of the spectrum. As we have introduced the spectrum for autoimmune disorders, let us go look into the similarities and differences of both ends, being the organ-specific and organ non-specific. Starting with the similarities, first, both ends of the spectrum may be characterized by circulating autoantibodies reacting with normal body constituents. Second, both may be found having increased immunoglobulin concentration in serum. Third, antibodies for either ends may appear in each of the main immunoglobulin classes. Fourth, diseases under either class may not always be progressive, meaning exacerbation and remissions may occur. And lastly, autoantibody tests are of significant and diagnostic value regardless of the spectrum. As for the differences, we may observe that there is a side-by-side comparison for organ-specific disorders and organ non-specific disorders. For organ-specific, we have antibodies and lesions that are organ-specific, as mentioned earlier in the definition. We also have clinical and serologic overlapping, and antigens are only available to lymphoid systems in low concentrations. This may be due to its tissue reactivity type. For organ non-specific disorders, we have antibodies and lesions, which are organ non-specific, which is also mentioned earlier. We have overlapping of SLE, RA, and other connective tissue disorders. And we have the antigens that are accessible at higher concentrations. This is also again due to tissue reactivity. Moreover, for organ-specific disorders, there may be an observance of lymphoid invasion or parenchymal destruction by questionable cell-mediated hypersensitivity or antibodies. And there may be a tendency to develop cancer in the organ since it is a single organ-specific. For organ non-specific disorders, we may have these characteristics of lesions caused by deposition of antigens, antibody complexes. And we may have a tendency to develop lymphoreticular neoplasia. At the early part of this report, we have said that autoimmunity may have emerged from the abnormal interactions of lymphocytes with the autoantigens. These interactions can be affected or may have been affected by antibody expression, which may have been regulated by influencing factors such as geneticity, patient age, and some exogenous factors. For genetic factors, rather than referring to direct genetic influence, it is more likely due to familiar aggregates, or the grouping or clustering of disorders within a specific family or lineage. Or it may be referring to multiple incidences of diseases. For example, an individual has a particular disease that affects the immune system. This emergence may be a factor or influence for the rise of another disease. This observance goes with the observed pattern of individuals acquiring pernicious anemia due to them having Hashimoto's disease. Moreover, as indicated by Mary Louise Sturgeon, autoimmune disorders and antibodies are more frequently found in women than men. And this may be a referring path of genetic factors. With patient age, it has been found that autoantibodies gradually increase in proportion with the individual's age, meaning that as one gets older, their autoantibody steadily increases as well. This observance has been found to have an end peak occurring around 60 to 70 years of age. Lastly, we also have exogenous factors such as UV radiation, certain drugs, certain microorganisms, viruses, and other relevant disease to be influencing the development of a particular autoimmune disorder. This may be through altering antigens. It has been established that if the immune system, or specifically its regulatory mechanisms, are functional, then autoimmune disorders are likely to be prevented. But what does happen if this becomes dysfunctional? First, autoantibodies may be produced targeting the self-antigens, hence the start of misidentifying of the word self. This produced matter will bind to antigens in the circulation to form circulation immune complexes. When these complexes accumulate, complements will be activated, subsequent to the release of inflammation mediators. These mediators in turn increases vascular permeability, attracting phagocytic cells to the reaction site, causing tissue damage on the location. Or this in turn can influence cytotoxic T cells to directly attack the body cells containing the target antigen. After that, Autoantibody and complement fragments tend to coat the target cell containing the antigen, which leads to its destruction by phagocytes or antibody-seeking K-type lymphocytes. This immunogenic mechanism and the development of an autoimmune response can be triggered or initiated by several stimuli. The stimulus itself, by nature, may influence the actual development of the response, and this stimulus can be the following flashed on the presentation. The stimuli can be the antigens that do not normally circulate in the blood, or it can be the altered antigens that arise because of chemical, physical, or biological processes. It can be a foreign antigen that is shared or cross-reactive with self-antigens or tissue components, or it could be a mutation of immunocompetent cells to acquire a response to self-antigens, or it could be because of the loss of the immunoregulatory function by T lymphocyte subsets. So either of these 5 given stimulus, it can affect or it can influence the actual development of the response. Now that we have presented the short overview of autoimmunity, let us move towards to the relevant disorders in line with such. We have cardiovascular disorders, pancreatic, neuromuscular, neuropathic, hematologic, endocrine, exocrine, renal, gastrointestinal, skeletal-muscular disorders. And all of this will be discussed by my groupmates.
For organ-specific and mid-spectrum disorders, the first disorder that we have is the cardiovascular disorders. Cardiovascular disorders are separated into 2, which are the vasculitis and the carditis. For vasculitis, this is the primary immunologic disease of blood vessels. It occurs as a primary disease process or a secondary manifestation of another disease. This is caused by the deposition of circulating immune complexes. Vasculitis is characterized by inflammation within blood vessels that causes injury or necrosis of the blood vessel wall, which leads to the narrowing, occlusion, or thrombosis of the lumen, or aneurysm formation or rupture, and also ischemia, which causes the major manifestations of vasculitic syndromes. Meanwhile, for carditis, this is a primary immunologic disease of the heart. It is characterized by the presence of inflammatory cells within the myocardium caused by immune sensitization to cardiac antigens. This can be caused by a variety of conditions including acute rheumatic fever, Lyme disease, and cardiac transplant rejection. Carditis results to impaired myocardial contractility. An example of carditis is the primary idiopathic myocarditis, which is the inflammation of the myocardium caused by macrophages and lymphocytes infiltrating the heart. Another example is the rheumatic heart disease. It exhibits antimyocardial antibodies that binds in vitro to foci in the myocardium and heart valves. Antimyocardial antibodies are responsible for the deposition of immunoglobulin and complement components, often found in patients with a recent myocardial infarction or streptococcal infection. The presence of antimyocardial antibodies is diagnostic of Dressler's syndrome or rheumatic fever. Another disorder are the collagen vascular disorders. So one disease under this disorder is the progressive systemic sclerosis. The development of progressive systemic sclerosis, or PSE, can be caused via intake of certain drugs such as bleomycin sulfate, tryptophan, and carbidopa. So another cause of the development of PSE can be due to occupational exposure to certain agents such as vinyl chloride, vibratory stimuli, and silicosis. PSE is known to occur in all races and is 3 times more frequent in women. Its signs and symptoms usually appears in the 3rd decade of life, which is the thickening of the skin, also termed as scleroderma, which also involves other organ systems. The skin manifestations progresses from stages of pitting edema to a sclerotic high-bound stage and atrophy or softening and the return toward normal. Raynaud's phenomenon is the most frequent manifestation of PSE. So PSE can either progress slowly and be chronically disabling, but it can also progress rapidly and be fatal. The immunologic manifestation of PSE is the development of antinuclear antibodies. Another disease under the collagen vascular disorders is what we call the eosinophilia myalgia syndrome. This is due to exposure to agents that causes eosinophilia myalgia syndrome or EMS. The most common cause is the ingestion of L-tryptophan and is also the most important predictor of EMS. So L-tryptophan is actually a widely used over-the-counter nostrum for various ailments such as insomnia, premenstrual syndrome, and anxiety. 50% of patients with EMS are known to develop scleroma derma-like manifestations.
I am Aliyah Aldeaviera to discuss the endocrine and exocrine gland disorders. So for the conditions in the endocrine gland, there are two major forms of autoimmune thyroid disease, which are the chronic autoimmune thyroiditis and Graves' disease. As for the exocrine gland disorder, we have the Sjogren's syndrome. To start off, we have the lymphoid chronic thyroiditis, or also known as our Hashimoto's thyroiditis, which is a classic example of an organ-specific autoimmune disorder, wherein an exact causative mechanism of it is actually unknown. However, it is believed that it has a relation towards an autoimmune process na nagde-develop ng circulating cytotoxic antibodies that targets the thyroid gland, which leads to the presence ng hypothyroidism, and one of which is in association with the presence of human leukocyte DR4 and DR5. Pero they aren't consistent in terms of the races and ethnic groups. For the epidemiology, this disorder can occur at any age, pero it is mostly diagnosed first for people in their 3rd to 5th decades of life. So, ibig sabihin, most often siya in middle-aged or older patients. And in terms of gender, women have been reported to acquire it more than male, and it is likely to have high possibility of inheriting traits na capable of developing antibodies na against po sa thyroid gland, and this scenario is common for multiple members of the family to inherit the same disease. For the signs and symptoms, we have number 1, sporadic goiter, which is the most common cause of lymphoid thyroiditis. We also have hypothyroidism, wherein ito naman ay isang common late sequela of this disorder, and histologically speaking, it is characterized by having diffuse lymphocytic infiltration, and the characteristics of the organ are having firm, diffusely enlarged, and non-tender thyroid gland that may be lobulated. For the diagnostic evaluation, the fine needle aspiration biopsy for the thyroid is useful in conjunction with clinical evaluation and serologic studies for the diagnosis of lymphocytic thyroiditis. We can also have performing histologic examination of thyroid tissues na capable of demonstrating infiltration of the entire gland with lymphocytes. We can observe germinal lymphoid centers are characterized to be the destruction and distortion of normal thyroid follicles that are apparent. And yung thyroid cells ng isang patient will remain intact but are hypertrophied. We also have chemiluminescent immunoassay na crucial in detecting anti-TPO autoantibodies. Itong ating TPO, or also known as the thyroid peroxidase, ay importante in the biosynthesis of thyroid hormones, wherein ang mechanism niya ay it catalyzes the iodination of thyrosyl residues in the thyroglobulin and the coupling of iothyrosyl residues to form T4 and T3. Pero kapag may autoantibodies specifically against TPO, it will inhibit the enzyme activity. And we also have the table representing the affected antigen targeted by antibodies that were mentioned from the manifestations, and these are the tests that will help in identifying such antibodies that affects the normal activity or the presence of the antigens. Let us now head on to the second major form of autoimmune thyroid disorder, which is the Graves' disease. So, Graves' disease is a form of hyperthyroidism, and when we focus on the laboratory chemistry assay, the expected result when a patient has Graves' disease is that it demonstrates low TSH, or the thyroid stimulating hormone, and there is an elevated free T4 levels. For the antibodies, patients with Graves' disease exhibit thyroid peroxidase antibody, or the anti-TPO, which we all know na si TPO is essential for the synthesis of thyroid hormones. Kaya, when there is an antibody, there will be the inhibition to do its job. The thyroid-stimulating immunoglobulin, on the other hand, detects the thyroid antibodies for the supplementary factor for diagnosing Graves' disease, since the TSH receptor antibody that may be present can discriminate between the presence of Graves' disease and the toxic nodular goiter. So we are now heading on the exocrine gland disorder, particularly the Sjogren's syndrome. Ano nga bang meron kay Sjogren's syndrome? As stated in the presentation, it is a chronic inflammatory disease of unknown cause that affects lacrimal, salivary, and other excretory glands. And this results in keratoconjunctivitis sicca and xerostomia. For the etiology, the development of Sjogren's syndrome is strongly supported by the association with human leukocyte antigen, or the HLA-B8 and the HLA-DR3. And there is also a clear evidence for excessive B cell activity that has been demonstrated, but it is not known whether this is caused by the abnormalities in the B cell or T cell. In its epidemiology, we have the primary form and the secondary form. The primary form means it isn't associated with other diseases, while on the secondary form, it is associated with RA and other connective tissue diseases. And it is stated that among 90% of patients with Sjogren's disease are women. Alongside, when an individual has this syndrome, it is noted that there is a 44-fold increased incidence of lymphoma. As stated in the presentation, these are the hallmarks for Sjogren's syndrome, wherein dry eyes, dry mouth, recurrent salivary gland pain, and swelling are the main clinical manifestations, whereas hoarseness, chronic cough, and increased incidence of infection also are observed. And for the dryness of vagina, this actually leads to having dyspareunia and itching. There's also the dysphagia and atrophic gastritis, along with extraglandular involvement. And lastly, experiencing renal tubular acidosis and vasculitis, wherein may involvement po ng peripheral nerves and the central nervous system results to having Sjogren's syndrome. Lastly, focusing on the immunologic manifestations, the immunologic characteristics of having Sjogren's syndrome are hypergammaglobulinemia, anti-nuclear antibodies, rheumatoid factor, autoantibodies to salivary duct and other antigens, and the lymphocyte and plasma cell infiltration. For hypergammaglobulinemia, usually kasi the antibodies are polyclonal, kaya it ends up to having hyperviscosity syndrome and purpura. When we are talking about anti-nuclear antibodies, they are speckled or homogeneous patterns present in 65% of patients with this syndrome. For rheumatoid factor naman, it is found on 90% of the patients, whereas the focus on salivary duct antigen, the antibodies present are frequently detected in patients acquiring secondary Sjogren's syndrome. As for the lymphocytic infiltration for the exocrine glands ng eyes, nose, mouth, respiratory tract, gastrointestinal tract, along with the vagina, it occurs wherein this infiltrate is comprised of B and T cells. Kaya in tissue culture, these cells are capable of producing large amounts of IgM and IgG, and the T cells are predominantly the helper cells.
Moving on to pancreatic disorders. First, the pancreas plays more than one role. It makes the insulin needed to regulate glucose. It also produces a large share of the enzymes you need to digest food and absorb nutrients. So I will be discussing several disorders of the pancreas in this part. The first one is insulin-dependent diabetes mellitus. For its etiology, insulin-dependent diabetes mellitus or type 1 diabetes mellitus is a disorder of deficient insulin production caused by immune destruction of the B cells of the pancreatic islets. Genetic susceptibility factors have been identified. T1D is associated with HLA, DR3, DR4, DQ2, and DQ8 antigens. For its epidemiology, T1D was previously called juvenile onset diabetes. Most patients develop T1D in childhood or early adolescence, but it may occur at any age. For its signs and symptoms, the central clinical feature is the requirement for exogenous insulin to maintain euglycemia. For its immunologic manifestations, patients with T1D have the following types of autoantibodies. First one is insulin autoantibodies, glutamic acid decarboxylase autoantibodies, and islet cell antigen 2. Next is latent autoimmune diabetes in adults. LADA is now recognized as a slowly developing form of autoimmune diabetes found in patients who are older than 35 years old. LADA is frequently misdiagnosed as type 2 diabetes. Autoimmune pancreatitis is a heterogeneous disease. This type of chronic pancreatitis is characterized by an autoimmune inflammatory process in which prominent lymphocyte infiltration with associated fibrosis of the pancreas causes organ dysfunction. For its etiology, although the cause of the disorder is unknown, it is thought to be a systematic autoimmune disorder. Epidemiology is that autoimmune pancreatitis is rare, but an increased number of cases have been reported since 2000. In addition, although this condition can occur in both genders, it is at least twice as common in men than in women. Most patients are older than 50 years at diagnosis. Signs and symptoms are variable. Many patients have jaundice and some have abdominal pain. For its immunologic manifestations, immunologic abnormalities include the following: hypergammaglobulinemia or elevated serum IgG or gamma globulin level in patients with enhanced peripheral rim, halo of the pancreas on CT, elevated serum IgG4 concentrations in patients with a diffusely enlarged pancreas, autoantibodies against carbonic anhydrase 2, lactoferrin, anti-smooth muscle antibody or ANA, and increased number of CD4 plus T lymphocytes and peripheral blood. Next part is the adrenal glands. Idiopathic adrenal atrophy is the disorder under this. It is the primary cause of Addison's disease. Idiopathic Addison's disease is usually diagnosed in patients because of low serum cortisol levels in the presence of elevated levels of corticotropin. For pituitary gland, Sheehan syndrome is under this. Sheehan syndrome lymphocytic adenohypophysitis is a disorder that causes a rapid decline in pituitary function. The disorder is distinguished by a mononuclear infiltrate of the pituitary gland and hypophysis. Next one is parathyroid gland. Idiopathic hypoparathyroidism is under this. It occurs as a childhood disorder in type 1 polyglandular syndrome and less often as an isolated disorder in adults. It is associated with complement-mediated cytotoxicity of parathyroid cells, indicating a specific immune response to parathyroid. For polyglandular syndromes, 3 syndromes of associated endocrinopathies have been defined as the polyglandular syndromes. Type 1 polyglandular syndrome involves mucocutaneous candidiasis and associated endocrinopathies that begin in early childhood. Type 2 polyglandular syndrome involves the combined occurrence of IDDM or autoimmune thyroid disease with Addison's disease. It is also called Smith syndrome, and this type of disorder is seen primarily in women in the second or third decade of life. And lastly is the type 3 polyglandular syndrome. It is defined as autoimmune thyroid disease occurring with 2 other autoimmune disorders including IDDM, pernicious anemia, and a non-endocrine organ system autoimmune disorder such as myasthenia gravis. So let's proceed into the next part, which are the renal disorders. Number 1 is renal disease associated with circulating immune complexes renal diseases. These are caused by non-renal antigens and their corresponding antibodies. These complexes are deposited in one or more several loci in the glomerulus. A renal complication of this type can be manifested in SLE. Number 2 is the renal disease associated with antiglomerular basement membrane antibody. These are directed against GBM of the glomerulus of the kidney. You can see this in the figure flash on the screen. These antibodies are induced in vivo against the basement membrane of the glomerulus and possibly that of the renal tubule or lung. However, the factors that stimulate antibody production are not well defined, but it appears likely that binding of drugs. Example is methicillin. High antibody titers of anti-GMB are suggestive of good Pasteur's disease, early SLE, or anti-GBM nephritis. And the last one for this part is the tubulointerstitial nephritis. Tubulointerstitial nephritis involves the renal tubules and has been associated with immune complex mediated disease. Precipitating factors can include drugs and possibly infection, as well as the involvement of transplanted kidneys.
The gastrointestinal disorders have different types of diseases that includes the atrophic gastritis and pernicious anemia, the autoimmune liver disease, the idiopathic biliary cirrhosis, the inflammatory bowel diseases, as well as the celiac disease. And first, we have the atrophic gastritis and the pernicious anemia. Autoimmune gastritis is characterized by chronic inflammation of the gastric mucosa, and that is usually caused by a dysfunctional immune system that targets the stomach lining. And in addition, persons with autoimmune gastritis may progress to pernicious anemia. And it is important to note that autoimmune gastritis is characterized by the presence of serum autoantibodies against gastric parietal cells that includes the proton pump, the cobalamin absorbing protein, as well as the intrinsic factor. The immunologic findings of the atrophic gastritis and the pernicious anemia, usually immunofluorescence can reveal antibodies against a lipoprotein cytoplasmic component of the gastric parietal cells in up to 90% of the pernicious anemia patients, and approximately 60% of atrophic gastritis patients do not have the hematologic abnormalities. And these antibodies may also be demonstrated in patients with other autoimmune diseases such as the thyroiditis. And in addition, the antibodies can be found in asymptomatic patients and in those older than 60 years old. And for the histologic findings, atrophic gastritis was almost always accompanied by pernicious anemia, is characterized by destruction of the gastric mucosa with lymphocytic infiltration in the absence of the parietal and chief cells. And usually the lesions are associated with a decrease in stomach acid and intrinsic factor synthesis. And this intrinsic factor normally binds with ingested vitamin B12 at one site and binds to receptors in the distal ileum on the other side. And as a result, the transport of the vitamin B12 across the ileum is impaired. The vitamin B12 or the cobalamin transport is mediated by 3 different binding proteins that are capable of binding the vitamin at its required physiologic concentrations. And as we can see on the table in our presentation, the source of the intrinsic factor is the stomach, while the function is for the intestinal absorption. And in a healthy state, the amounts of intrinsic factor secreted by the stomach greatly exceed the quantities required to bind ingested cobalamin in its coenzyme forms. Next is the transcobalamin 2. TC2 is a plasma polypeptide that are synthesized by the liver and probably by several other tissues. And TC2 turns over very rapidly into plasma, and it acts as the acceptor and the principal carrier of the vitamin to the liver and to the other tissues. And lastly, we have the R proteins, and their function is unknown, but they appear to serve as storage site and a means of eliminating excess cobalamin and unwanted analogs from the blood circulation through the receptor sites on the liver cells. And R proteins are produced by leukocytes and perhaps with other tissues, and they are present in plasma as transcobalamin 1 and transcobalamin 3, as well as in the saliva, milk, and other body fluids. Next, we have the autoimmune liver disease. And autoimmune processes are believed to be the possible cause of chronic liver diseases. And for the signs and symptoms, we have the hypergammaglobulinemia, the prominent lymphocyte, as well as the plasma cell inflammation of the liver, and lastly, the presence of one or more circulating tissues antibodies. And these manifestations suggest an organ localized autoimmune pathogenesis. And we have the autoimmune hepatitis, and autoimmune hepatitis is formerly known as chronic active hepatitis. It is an inflammatory condition most common in young women, and it is characterized by prominent lymphocyte and plasma cell inflammatory changes which start in the portal tracts. And in some patients, this condition results from a chronic viral infection or inflammation, but in others, a number of immunologic abnormalities are present to varying degrees in addition to hypergammaglobulinemia and an elevated erythrocyte sedimentation rate. And a defect in immunoregulation is often demonstrated, which may lead to unrestrained immunoglobulin production. And in some cases, this disease is referred to as leukoid hepatitis, and patients with aggressive chronic active hepatitis have a poor prognosis, and a significant rate of mortality is reported 5 years after the diagnosis. Next, we have the idiopathic biliary cirrhosis, and it is a slowly progressing disease that begins as an infectious inflammation in the bile ducts of young to middle-aged women, and there has been a rise in the incidence of the disease in the families. And as we can see, the expected laboratory results of the idiopathic biliary cirrhosis includes the increased serum IgM, the depression of cellular immunity with prominent decreases in suppressor T cells that are commonly associated with the autoimmune disorders, and it is also believed that tissue damage is thought to be caused by an unmodulated attack on host tissue antigens. And in addition, a high antimicrobial antibody titer strongly supports the primary biliary cirrhosis, while the absence of the mitochondrial antibodies strongly indicates that PBC is not present. And low mitochondrial antibody titers, on the other hand, are common in the other types of the liver diseases. Next, we have the inflammatory bowel disease, and it is the collective name given to Crohn's disease and the ulcerative colitis. And in addition, the Centers for Disease Control and Prevention estimates that the EBD, which is more common among the Ashkenazi Jews than other groups, and usually it affects more than 1 million Americans. And moreover, there are many factors that affect the onset and development of the idiopathic bowel disorder, and the crux of the disease is an abnormal immune response to harmless bacteria in the gut that benefits the host by providing energy and nutrients. And in the idiopathic bowel disease patients, these microorganisms becomes target for attack by the immune system, and the inflammation seen in the IBD patients has been linked to the following. That includes the presence of increased levels of inflammation promoting the cytokines, as well as the protein molecules used by cells of the immune system to communicate with each other. And some studies have suggested that one cytokine, the IL-12, is a crucial mediator of this disease. And the IL-12 causes inflammation by activating a class of different immune cells, the type 1 helper T cells, which in turn secrete pro-inflammatory molecules such as the interferon Y, and the tumor necrosis factor alpha, and these pathways have been suggested as therapeutic targets for human idiopathic bowel disease. And for the immune markers, the following serologic markers have been found to be useful in the diagnosis and differentiation of CD and UC. This includes the deoxyribonuclease, the anti-Saccharomyces cerevisiae antibody, and this is present in the sera up to 70% of the CD patients. In addition, the pancreatic antibody that observed in approximately 30% of the CD patients, and lastly, the anti-outer membrane porin from the Escherichia coli. Now we have the celiac disease, and it is a lifelong autoimmune intestinal disorder that are found in individuals who are genetically susceptible, and usually they have damage to the mucosal surface of the small intestine that is caused by an immunologically toxic reaction to the ingestion of gluten, and it interferes with the absorption of nutrients. And it is important to note that celiac disease is a unique type of disease because of the specific food component which is known as gluten. And gluten is the common name for the offending proteins in specific cereal grains that are harmful to those with celiac disease. And these proteins are found in all forms of wheat and related grains, and they must be eliminated to those people with celiac disease. And the clinical immune disorders that are associated with celiac disease includes the selective IgA deficiency, the autoimmune thyroid diseases, the chronic autoimmune hepatitis, the lupus erythematosus, the Sjogren's syndrome, as well as the type 1 diabetes. The skeletal muscle disorders includes the inflammatory myopathy, and polymyositis and dermatomyositis are the most common expressions of a group of chronic inflammatory disorders, and it can be subclassified into the following 6 categories. And as we can see in the presentation, the following 6 is the category for the chronic inflammatory disorders. And all these disorders have skeletal muscle damage by a lymphocyte inflammatory process, resulting in symmetric weakness predominantly of the proximal muscle. And the polymyositis may be accompanied by inflammation at other sites, especially in the joints, the lungs, and the heart. The term dermatomyositis is used for the disorder when the clinical features of disease are accompanied by characteristic inflammatory manifestations in the skin. And evidence has suggested that polymyositis and dermatomyositis result from the immune destruction. And for the etiology, the cause of these disorders remain unknown, but they may be developed in genetically susceptible persons after the exposure to environmental agents that induce immune activation and inflammation. And infection is the most likely initiating event. As part of the inflammatory response to the infection, susceptible individuals develop a persistent cell-mediated immune attack that continues to destroy the muscle after the acute infection is eradicated. And it is important to note that polymyositis and the dermatomyositis are more common in females, with peaks of occurrence in childhood and in the 5th decade. And for the signs and symptoms, this includes the proximal muscle weakness, fatigue with low-grade fever that can lead to atrophy in progressive diseases, and the muscle biopsies in patients with dermatomyositis have shown vasculitis, with IgG and complement deposition in the vessel walls in children and infrequently in adults. And for the skin disorders, there's a wide variety of autoimmune disorders that are associated with the skin manifestations. And for the immunologic assays, there are 2 immunologic assays that can be used in conjunction with other clinical information, includes the measurement of antibodies to the basement membrane area of the skin and of antibodies to the intercellular substance of the skin. And the anti-skin or the dermal epidermal antibodies are present in more than 80% of patients with bullous pemphigoid, but the absence of the antibodies does not rule out the disorder. And for the anti-skin interepithelial antibodies, it can be detected in 90% of patients with pemphigus. And the autoimmune disorders that are associated with skin manifestations includes the discoid lupus, the bullous pemphigoid, the pemphigus group, and the dermatitis herpetiformis.
So this topic is about the autoimmune hemolytic anemia. It can be classified into 4 groups. First, the common one is the warm reactive autoantibodies. 2. Cold reactive autoantibodies. Third, the rare one, paroxysmal cold hemoglobinuria. Lastly, drug-induced hemolysis. So, the warm autoimmune hemolytic anemia. This anemia is associated with antibodies reactive at warm temperature. In more than 75% of cases, the erythrocytes are coated with both IgG and complement, although some may demonstrate coating with IgG alone. Also, negligible serum autoantibody exists because the antibody reacts optimally at 37 Celsius or 98.6 Fahrenheit and is being continuously absorbed by RBCs. Next, second one is the cold autoimmune hemolytic anemia, also known as CHAD. It can be acute or chronic. It is the most common type of hemolytic anemia associated with cold reactive autoantibodies. The acute form is often secondary to the Mycoplasma pneumoniae infection or lymphoproliferative disorder. The chronic form is in older patients and produces mild to moderate hemolysis. So here in CHAD, a cold reactive IgM autoantibody reacts with RBCs in the peripheral circulation when the body temperature falls to 32 Celsius or 89.6 Fahrenheit or lower and binds complement to the cells. Therefore, complement is the only globulin detected on the erythrocytes. Elutions prepared from RBCs at warm temperature or 37 Celsius will not demonstrate any antibody reactivity in the eluate. The third is the paroxysmal cold hemoglobinuria, previously associated with syphilis, but now seen more often as an acute transient condition secondary to viral infection, particularly in young children. It may also occur as an idiopathic chronic disease in older people. The autoantibody is an IgG protein that reacts with RBCs in colder parts of the body. This produces complement components C3 and C4 to bind irreversibly to the erythrocytes. At warmer temperatures, RBCs are hemolyzed and the antibody elutes from the cells. Eluates are also non-reactive. This IgG autoantibody, biphasic hemolysin, can be demonstrated by performing the classic Donat-Landsteiner test. The autoantibody has anti-P specificity and reacts with all except the rare P or PK phenotypes. Exceptions that include examples with anti-IH specificity have been described. Lastly, the drug-induced hemolysis. Coating of the RBCs demonstrated by a positive direct anti-human globulin test or DAT result may be drug-induced or accompanied by hemolysis. The reactivity has been described as being caused by 4 basic mechanisms. 1 is drug absorption, 2 immune complexing, 3 membrane modification, and 4 autoantibody formation. For the drug absorption, penicillin is a representative example of an agent that displays drug absorption. In this type of mechanism, the drug strongly binds to any protein, including RBC membrane proteins. This binding produces a drug RBC hapten complex that can stimulate antibody formation. The antibody is specific for this complex and have no reaction will take place unless the drug is absorbed on erythrocytes. The second mechanism is the immune complexing. It is associated with a variety of drugs, including phenacetinine, quinine, rifampin, and stibofen. In this interaction, the drug and the antibody form a complex in the serum and attach non-specifically to the RBCs. Once attached, this complex initiates the complement cascade, which culminates in the intravascular hemolysis. The immune complex may dissociate from the RBC membrane after a complement activation and attach to another erythrocyte. This allows a small amount of drug to produce a severe anemia. When the offending drug is discontinued, the hemolytic process disappears quickly. Third mechanism is the membrane modification. Drugs of the cephalosporin occasionally cause a positive DAT result with polyspecific and monospecific anti-human globulin antisera by membrane modification. In this type of mechanism, the drug alters the membrane so that there is non-specific absorption of globulins including IgG, IgM, IgA, and complement. Hemolysis is not a common complication in this type of membrane augmentation. The last mechanism is the autoantibody formation. Drugs such as methyldopa, levodopa, and mefenamic acid have been implicated in positive DAT results caused by autoantibody formation. The autoantibody formed recognizes a part of the RBC and therefore reacts with most normal RBCs. Some drug-induced autoantibodies have been shown to have specificities that appear to be of the Rh type, but most have no apparent specificity. Antibody production ceases with withdrawal of the drug. Next is the idiopathic thrombocytopenic purpura, or the ITP. Patients with ITP usually demonstrate petechia, bruising, menorrhagia, and bleeding after minor trauma. It can be acute or chronic. Children are most often affected with the acute type, whereas adults predominantly experience the chronic type. This common disorder may complicate other antibody-associated disorders, such as thrombocytopenia. Pernicious anemia is a megaloblastic anemia characterized by a variety of hematologic and chemical manifestations. This is caused by a deficiency of vitamin B12 that results from the patient's inability to secrete intrinsic factor. In autoimmune cases of PA, anti-IF or antiparietal antibodies have been reported. Demonstration of these antibodies supports the theory that PA is an autoimmune disorder. So, most patients with PA have parietal cell antibodies. In the presence of these antibodies, gastric biopsy almost always demonstrates gastritis. Low antibody titers to parietal cells are often found with no clinical evidence of PA or atrophic gastritis and are sometimes seen in older patients. Moving on to the neuropathies. A neuropathy is a derangement in the function and structure of peripheral motor, sensory, or autonomic neurons. Autoimmune disorders are one of the disease categories causing neuropathy. In many cases, evidence supports autoimmune pathogenesis. Demonstration of the relationship between specific neuropathic syndromes and antibodies directed against glycolipid and neural antigens are important scientific advances. In the autoimmune neuropathies, Antibodies directed against peripheral nerve components are associated with specific clinical syndromes. In addition, many autoimmune neuropathic syndromes are associated with malignancies, which they often precede. Recognition of these syndromes can lead to early identification and treatment. Most antibodies implicated in the development of autoimmune-mediated neuropathies are directed against carbohydrate epitopes or glycoproteins or glycolipids. Systemic sclerosis or scleroderma is an autoimmune disease characterized by a wide spectrum of clinical, pathologic, and serologic abnormalities. These serum autoantibodies are helpful markers because they correlate with certain clinical features of systemic sclerosis.
Next topic is all about the neuromuscular disorders. Several important neurologic disorders are related to the immune system. The immune system may play an important role in the pathogenesis and cause of myasthenia gravis and multiple sclerosis. In addition, amyotrophic lateral sclerosis or the ALS has become one of the prime subjects of modern neurologic research. First neuromuscular disorder is the amyotrophic lateral sclerosis. Along with Alzheimer's disease and Parkinson's disease, ALS is one of the so-called degenerative diseases of the aging nervous system. It has also been suggested that ALS patients have a higher incidence of lymphoproliferative disease lymphoma, Waldenstrom's macroglobulinemia, and myeloma. This also seems to be an increased frequency of antibodies to a neuronal ganglioside GM1. Next is the inflammatory polyneuropathies. This group of idiopathic disorders, which includes the acute disorder Guillain-Barré syndrome or the GBS, is characterized clinically by the subacute onset of generally symmetric weakness ranging from modest lower extremity weakness to total life-threatening involvement of motor and even cranial nerves. Unstable blood pressure and potentially fatal arrhythmias have also been observed. Progression of GBS can be rapid, however, most patients do recover. Next disorder is the myasthenia gravis. It is a disorder of the neuromuscular junction characterized by neurophysiologic and immunologic abnormalities such as the thymic hyperplasia with genital follicles, increase in thymic B cells, thymoma, expression of AChR binding antibody and AChR blocking antibody, and also it is associated with other autoimmune diseases. Multiple sclerosis. It is the most common demyelinating disorder of the CNS related to the abnormalities of the immune system. It is characterized by regions of demyelinization of varying size and age scattered throughout the white matter of the CNS. Demyelinization plaques have a propensity to form in the cerebrum, optic nerves, brainstem, spinal cord, and cerebellum. And for the etiology of multiple sclerosis, after more than a century of study, the cause of multiple sclerosis remains unknown. Viral infections such as human herpesvirus type 6 is highly suspected but unconfirmed. In addition, Epstein-Barr virus or the EBV, which causes infectious mononucleosis and is associated with other diseases, may increase the risk of multiple sclerosis. For the epidemiology, the incidence, prevalence, and mortality rates of multiple sclerosis vary with latitude. Multiple sclerosis is rare in tropical and subtropical areas. The higher risk for multiple sclerosis in Europeans and in relatives of patients with multiple sclerosis and the existence of multiple sclerosis-resistant ethnic groups support a genetic predispositions to multiple sclerosis. A low prevalence of multiple sclerosis occurs in Africa, India, China, Japan, and Southeast Asia. And for the pathophysiology, multiple sclerosis results from T-cell dependent inflammatory demyelination of the CNS. The inflammatory demyelination caused by T lymphocytes induces B lymphocytes to produce anti-myelin antibodies. The ongoing pathologic process involves the formation of CNS lesions called plaques, characterized by inflammation and demyelinations. And for the signs and symptoms of multiple sclerosis, it begins as a relapsing illness with episodes of neurologic dysfunction lasting several weeks, followed by substantial or complete improvement. Initial signs of multiple sclerosis are difficulty walking, abnormal sensations such as numbness, possible pain, and ineffective vision. Primary symptoms caused by demyelination include fatigue, bladder and bowel dysfunction, loss of balance, loss of memory, slurred speech, difficulty swallowing, and seizures. And also depression is a common symptom. Diagnostic method of multiple sclerosis includes the magnetic resonance imaging or the MRI, which is a key imaging modality for establishing a diagnosis of multiple sclerosis. No single laboratory test results confirms a diagnosis, but appropriate laboratory test results must be evaluated carefully. It is also important to rule out infectious diseases such as Lyme disease, syphilis, and human T-lymphotropic virus type 1 infection. Immunologic manifestations of multiple sclerosis includes the anti-myelin antibodies, myelinotoxicity and glial toxicity of serum and cerebrospinal fluid in vitro cell-mediated immunity by blood and cerebrospinal fluid cells to myelin components, oligoclonal increase in cerebrospinal fluid immunoglobulin, and the increase in certain HLA and IA antigens. For the detection of oligoclonal bands, oligoclonal immunoglobulins may be seen in serum and CSF. Electrophoresis on cellulose acetate will rarely resolve an oligoclonal pattern. Therefore, electrophoretic media with greater resolution, such as the agar or agarose gel, are required, and both require the use of concentrated CSF. High-resolution electrophoresis attempts to achieve better resolution of proteins beyond the classic 5-band pattern, while the immunofixation has been used in some research studies to show that the oligoclonal bonds seen in CSF protein patterns are made up of primarily of IgG. And for the significance of oligoclonal bonds, if oligoclonal bonds are present in CSF but not in the serum, they are the result of increased production of IgG by the CNS. CNS production of IgG occurs in the subarachnoid space of the brain in conjunction with local accumulation of immunocytes. And for the clinical findings, total CSF protein in patients with multiple sclerosis is usually normal or slightly elevated. In general, patients with no neurologic diseases have an IgG concentration of less than 10% of the total CSF proteins. Almost 70% of multiple sclerosis patients typically have IgG concentration of 11% to 35% of total CSF proteins. And for the treatment of multiple sclerosis, corticosteroid therapy is a common symptomatic treatment for disease relapses. The relapsing form of multiple sclerosis can be treated with immunomodulators such as interferon beta 1b, interferon beta 1a, and glatiramer acetate or the Copaxone. All these drugs have been approved by the U.S. Food and Drug Administration, and the newest medication for multiple sclerosis is fingolimod or the Gilenya, which was approved by the FDA in September 2010. Next topic is all about neuropathies. A neuropathy is a derangement in the function and structure of peripheral motor, sensory, and autonomic neurons. Autoimmune disorders are one of the disease categories using neuropathy. In many cases, evidence supports autoimmune pathogenesis. Demonstration of the relationship between specific neuropathic syndromes and antibodies directed against glycolipid and neural antigens are important scientific advances. In the autoimmune neuropathies, antibodies directed against peripheral nerve components are associated with specific clinical syndromes which is shown in the table. Knowledge about these syndromes and antibody tests can be used to identify a treatable neuropathy. In addition, many autoimmune neuropathic syndromes are associated with malignancies, which they often precede. Recognition of these syndromes can lead to early identification and treatment.
These are the main references that we have used for the presentation. And we hope that you have learned something from us, most especially in regards to the nature and characteristics of autoimmune disorders. Thank you for listening and have a COVID-19 free day.